Rajani ma'am, if Sikandar sir or Rupa ma'am won't join, we'll hand over session to you ma'am. Is it fine for you ma'am? Rajani ma'am?
Yeah, I'll take care.
Yeah, sure ma'am. At exact 7, we'll start the session ma'am.
Sure,
If both of them won't join, we'll hand over session directly to you ma'am.
sure. I welcome you all for every Friday's Women's Imaging series under the aegis of ICR.
Ma'am, I'm starting the session. Good evening, everyone. I welcome you all to the ICRI Radiology Teaching Program. I request the organizers to kindly begin the proceeding. Over to you, Rajani ma'am.
Yeah. Good evening, one and all. I welcome all of you for every Friday's Women Imaging series under aegis of ICRI. And I would like to introduce the speaker of the day, Dr. Veenu Singla, Professor of Radiodiagnosis, working at PGI Chandigarh, which has a fully equipped breast imaging facility. She has published more than 65 articles, author and co-author of different chapters in various textbooks. She is a governing council member of BC Breast Imaging Society for the current 2021 and 23. She is also a member of various professional bodies like IRIA, ESR, ISBIR, BC, and SBI. She is a guide and co-guide to MD, DM, and breast imaging fellow students. At the end of session, ma'am will be posting few spotters. I request all the delegates to answer in the chat box. Now, I would like to invite Professor Veenu Singla for a case-based review of today's lecture. Over to you, ma'am.
Thank you, Dr. Rajni, for the kind introduction, and thank you, Team ICRI, for having me here. It's always a privilege to share cases and to discuss with the students. So I start sharing my screen.
Yes, ma'am.
So in this case-based discussion, I will be taking the students through various aspects of the women's imaging cases that we come across in our day-to-day practice. I will be taking the students through congenital malformations, right from the common and uncommon malformations to the acute and chronic pelvic pain disorders. So my talk will be under the following headings: congenital malformations, benign uterine lesions, uterine sarcomas, adnexal masses, and acute and chronic pelvic pain disorders. So beginning with the first topic, that is the congenital malformations of the uterus. My first patient was a 26-year-old female who presented for a routine viability scan in her first trimester. She had past history of severe dysmenorrhea and chronic pelvic pain. So when we saw her, we could see that there was an intrauterine gestation sac. And on transabdominal scan, the intrauterine gestation sac had a fetal pole and cardiac activity was also seen. In addition, there was, and this intramural, I'll just take the laser. So in addition to this sac, we could see this intramural, well circumscribed cystic structure, which had an endometrial lining. So the differential diagnosis was of a rudimentary horn versus a degenerated fibroid versus an accessory cavitated uterine mass. So we could not definitively reach a diagnosis, and the gynecologist, because she wanted to rule out ACUM, which is an accessory cavitated uterine mass, she requested for an MRI as the patient was herself a doctor. And on MRI, we could see a well-defined rounded intramural cavitated mass adjacent to the sac, which was a normal gestation sac having a viable pregnancy. And this non-communicating intracavitary mass was in the left uterine wall, and it was filled with hemorrhagic contents, which were hyperintense on both T2 and T1 weighted images. The cavity was lined with T2 weight, on T2 weighted, we could see that the cavity was lined with hyperintense endometrium. Can you appreciate this lining endometrium? And the junctional zone of this cavity, which was intramural in location, it was thickened. And the endomyometrial interface was indistinct. As we normally see, there is a nice endomyometrial interface, and the junctional zone of this cavity was up to 13 millimeters. And on the other hand, the main uterine cavity that was normal in size and shape, and both the cornua was seen normally, which ruled out ultrasound diagnosis of a rudimentary horn. Because normally rudimentary horns, they are not intramural in location. And in such intramural kind of a location of a cystic structure that is lined with an endometrial cavity that has a thickened junctional zone and an indistinct endometrial interface, we should think of an accessory cavitary uterine mass. And this cavitary uterine mass was attached just below these round ligaments. This was just below the round ligaments. Now, where is this round ligament seen normally? This is a fibromuscular band which extends from the anterolateral aspect of the uterus anteriorly between the layers of the broad ligament, and it passes through the deep inguinal ring to the inguinal canal. And its attachment are the cornu of the uterus just below the origin of the uterine tube and the soft tissue of the labia at the mons pubis. So this classical location of this intramyometrial cystic lesion just below the round ligament further favors the diagnosis of ACUM. So the junctional zone and the myometrial signal intensity of the main uterine body, they were normal. This was showing increased junctional zone thickness and indistinct myometrial interface, as I've already told. And these were the T2 weighted space sequences. Okay. And so the possibility of ACUM was kept, and the patient was followed up. And why the possibility of fibroid with degeneration was not kept? Because it was classically lined with endometrium and had hemorrhagic contents and had that architecture, tri-layered architecture of an accessory cavitated uterine mass. Now, what is an accessory cavitated uterine mass? Accessory and cavitated uterine mass is a rare uterine anomaly in which we see a uterus-like accessory mass locally confined to the myometrium, but having no communication to the main uterus. So this is also known as accessory uterine cavity or cystic adenomyoma. Now, there are a couple of theories of development which have been formulated to explain this entity. It may be congenital, it may be a heterotopia or a metaplasia. So it is considered as a type of heterotopia or a metaplasia more, in which a uterus-like structure forms within the wall of the uterus itself. So it usually, because the patient is in the reproductive age, and this cavity also has a lining endometrium, it presents at a young age with symptoms of pain and dysmenorrhea. And the main uterus is normal, like in the index case, and doesn't show any features of adenomyosis, while the myometrium of the acum shows features of adenomyosis in the form of junctional zone thickening and indistinct endomyometrial interface. So what are the imaging criteria? The main imaging criteria is the location, with acum being located along the uterine wall under the round ligament, and the histological layer organization of the trilayer organization of endometrium, junctional zone, and the myometrium, unlike adenomyoma, which shows only thin-walled cysts. So blood degradation products are seen within the acum because it bleeds cyclically, and no adenomyosis is seen usually in the main uterus because the main uterus is in continuity with the normal cervix and the normal vagina. So adenomyosis is seen only in the acum part. So on ultrasound, usually we need to suspect this anomaly on ultrasound, in which we see a mass within the myometrium having a variable cystic component depending on the blood degradation products at that point of time, and it can resemble an endometrioma with low-grade echoes, and sometimes it is difficult to differentiate an acum from a unicornuate uterus with obstructed rudimentary horn. And MRI can help in such cases by demonstrating both the cornua of the main uterus. So on MRI, we see that the index uterus is normal, and this cavitated mass, it is under the round ligament attachment. It is just inferior to the round ligament attachment and is filled with T2 hyperintense and T1 hyperintense blood degradation products, and has an endometrial lining. And MRI, of course, is superior in some body habitus like an obese patient, and it can best demonstrate the normal uterus, the normal cornua, and the ovaries, which help to rule out other lesions in this region. Now, this was another case of acum showing an intramyometrial cystic mass, which was not communicating again with the main uterine cavity. Now, this mass again has that tri-layered uterus architecture and is lined with endometrium, has a junctional zone, and is classically again under the location of the round ligaments. So both the cornua of the main uterus, this and this, are visualized. Here also the cornua are visualized, and this rules out a rudimentary horn. So unicornuate uterus with obstructed rudimentary horn stands the diagnosis. However, in a unicornuate uterus, we see a banana-shaped small uterine cavity and a single cornua, as opposed to acum, where we can see both the cornua. I will show you a companion case of a unicornuate uterus with a rudimentary obstructed horn also. Now, this was a 26-year female in which we could see a banana-shaped uterus and having a single cornua from which a fallopian tube was seen with free spill. And this classical appearance on HSG, we know we are dealing with a unicornuate uterus, but we need to do an MR in these cases. Why? Because in these cases, normally we can see, in addition to the main uterine horn that we could see on HSG, we can see associated uterine remnants. And these uterine remnants may be having functional endometrium. Now, if these uterine remnants have functional endometrium, then these are the cause of concern to the gynecologist, as they cause dysmenorrhea due to cyclical bleeding within these rudimentary functional uterine remnants. And in this patient, we could see that this was the unicornuate uterus that we could see on HSG. While on MR, there is way more information. We can see that in addition to this unicornuate uterus, we can see the non-communicating functioning left uterine remnant. And there is this spectrum of endometriosis due to obstruction, due to back bleeding of blood into the peritoneal, and it is leading to endometriotic cysts with a cyst formation within the left ovary. And there was also component of deep pelvic endometriosis here, T2 hyperintense, ill-defined T2 hyperintensities along the myometrium of the left uterine segment was seen. And so this was a full-fledged case of endometriosis in a unicornuate uterus with associated non-communicating functional uterine segment. Just see if the video can work. So on the SAG images, we could trace the index uterus into the cervix and vagina, which were normal, and we can well appreciate the rudimentary horn filled with blood degradation products. And on T1 weighted images, we could see that the degradation products within the rudimentary horn were T1 hyperintense, as well as the left endometrioma was also hyperintense, and there was this tube-like structure along the left endometrioma, which was a left-sided hematosalpinx. And we can clearly see here where I'm stopping this component of deep pelvic endometriosis, which is T2 weighted hyperintense structures adjacent to the myometrium of the left rudimentary horn. These could be better seen on T1 weighted images. Here in these static images, I will show you with the pointer. Here we can see these T2 weighted, T1 weighted hyperintense, DIE, deep endometriosis, deep pelvic endometriotic component, along with this endometrioma and the blood-filled rudimentary cavity. So the final diagnosis of a right unicornuate uterus with associated non-communicating left atrophic uterine segment was given. And as per the this ASRM classification, this description is given as a unicornuate uterus with non-communicating left atrophic uterine segment and with Eschre, which describes the uterine, cervical, and vaginal anomalies separately. The unicornuate uterus with rudimentary functional cavity, which is non-communicating, forms U4A. Cervix 0 is normal, vaginal 0 is a normal vagina. So this is the Eschre classification. In our institute, we normally give the reports with ASRM classification followed by the Eschre classification. So what is a unicornuate uterus? This is abnormal or failed development of one of the paired Mullerian ducts. We have already studied in the various lectures how the Mullerian ducts diffuse to form the uterus. So if there is failure of development of one of the ducts, there is this formation of unicornuate uterus, which is also known as hemiuterus. And there is associated rudimentary horn in almost 2/3 of these cases. And when present, the rudimentary horn can be non-cavitatory in 33%. It can be cavitatory, non-communicating in 22%, and cavitatory communicating in 10%. So it is this cavitatory horn that leads to problems because this is lined with endometrium and it undergoes cyclical bleeding. So if this cavitatory non-communicating horn, it is this cavitatory non-communicating horn that usually these patients undergo surgery because of associated stigma of endometriosis. So in these patients, we should always do a T2 coronal screening sequence to look for renal anomalies, as up to 40% of these patients have associated renal anomalies, renal agenesis being the most common in 67% of these cases. And as I've already told, endometrial tissue in the rudimentary horn is the main cause of symptoms. Now, this is ASRM classification, which is freely available on net, and it has been upgraded in 2021 very recently. And I suggest all the residents to have a hard or a soft copy with you, because in this classification, basically they have classified the anomalies into 9 main categories. The first 3 are the anomalies of formation that include Mullerian agenesis, cervical agenesis, and the unicornuate uterus. And the next are the failure of fusion. Next two include are the failure of fusion, that include the uterus diadelphus and the bicornuate uterus. Then is the failure of resorption in the next 3, that is the septate uterus and the various septum and the various kinds of vaginal septi. And the last but not the least are the complex anomalies. Now ours was the case of this unicornuate uterus. Now if we go into this detail of the unicornuate uterus, we see unicornuate uterus can be isolated without a rudimentary horn, as in this case. Okay, so it can be with a distal atrophic uterine segment, as seen in the second diagrammatic representation, when the atrophic uterine segment is distal, means away from the unicornuate uterus. In the second diagrammatic representation, they have shown that it does not have any functional endometrium. Now, in the third, they have shown it is a distal uterine remnant with a functional endometrium. And in the fourth, the ASRM classification is showing a unicornuate uterus with associated atrophic uterine segment. So when the uterine remnant is very close to the unicornuate uterus, they call it associated atrophic uterine remnant. And when it is away from the unicornuate uterus, they call it distal uterine remnant. So this is very important. In our case, it was an associated atrophic uterine remnant with functional endometrium. So this classification is very nicely described in this article published in 2021. And I suggest all the residents to go through this. And when we talk of congenital anomalies, the discussion cannot be complete without showing you a case of a septate uterus, which is the most common Mullerian duct anomaly. In this patient who had recurrent pregnancy losses, these patients, they normally conceive and they normally have a little lesser fertility, but then they have recurrent miscarriages and abortions. So this HSD showed 2 uterine cavities divided right up to the cervical canal. Okay, so here we can see that this is divided into 2, and this 3D rendered coronal ultrasound is again nicely demonstrating complete separate uterus, showing a normal external contour and a septum dividing the endometrial cavity, and this septum is extending right into the cervix. Now, this external contour of the fundus is very important, and sometimes we cannot see this external contour on ultrasound, and then MR is needed to differentiate bicornuate from septate uterus. So in a septate uterus, the external contour is either flat or it shows mild dipping, which is less than 1 centimeters. So in this case, we could see that it was a complete septate uterus with the septum going right up to the cervix. Here we can see even in the cervix region, the septum is extending and is dividing it into 2. Both the ovaries were normal, as they are normal in most cases of Mullerian duct anomalies. And we should always, in the septate uteri, we should always include the constitution of the septum in our reports, as it is very important for the gynecologist. And in this case, the septum was muscular in the upper part and fibrous in the lower part. The gynecologist accordingly plans whether he has to do a hysteroscopic removal, which is done in cases of fibrous septum, or a laparoscopic removal, which is done in cases of muscular septum. So this should be always included, and a T2 coronal screening of the kidneys should always be done in cases of MDAs. And again, talking of these MDAs, you should always report them according to ASRM latest classification. And the key diagnostic features to differentiate a bicornuate from a septate uterus is intercornual distance of more than 4 centimeters in a bicornuate uterus, and an intercornual angle of more than 105 degrees, and external fundal dipping of more than 1 centimeters in a bicornuate uterus. While in a septate uterus, it is usually a subtle fundal dipping, or the external contour is flat. The intercornual distance is less than 4 centimeters, and an acute intercornual angle is present. So septate uterus should always also include, in addition to these measurements, whether the septum is constituted by muscular or fibrous tissue. Now, this is the second commonly used classification, which is the Escher or the ESGE, the European Society of Gynecological Endoscopy. And this classification, it is based on uterine, cervical, and vaginal anomalies. And in this, they have divided the uterine anomalies into main class. It includes a main class of these uterine anomalies, and which is further divided into subclasses, and the vaginal and cervical anomalies are taken as the coexistent classes. So the main classes include U0 to U6. The main class U0 is a normal uterus. Then it goes right up to aplastic uterus, which is U5, and unclassified malformations, which are U6. So in our case, it was a septate uterus, which was a complete septate uterus. So it was U2B, and the cervix also has septum, so it was C1, and vagina was normal, so it was V0. So it was, this is how it is reported. U2B, C1, V0. So this is how the Escher classification goes. And as I have told you, you can give a slash and report according to both the classifications. So coming to benign uterine lesions. Now, leiomyomas are something which all of us know how they look like on ultrasound. And the first image is of a transvaginal ultrasound showing a subserosal leiomyoma distorting the outer contour of the uterine wall. And this is a macroscopic specimen showing how an intramural leiomyoma looks. And this was an MRI showing a polyfibroid, or a uterus showing multiple fibroids. And this was a 44-year-old female. And I just took out this image to show you how leiomyomas, classical leiomyomas look. They are T2 hypointense. They are typically T2 hypointense, and sometimes they have these speckled hyperintense spots. And there was this pedunculated subserosal leiomyoma, which was present in the posterior cul-de-sac also. And in these leiomyomas, again, we should look for associated problems like degeneration, and which may be like in this patient. This was a non-pregnant patient who had abdominal pain for the last 3 days, and she was like undiagnosed, and ultrasound just showed some cystic change in the leiomyoma, and we were not sure what we were dealing with. And because it was a non-pregnant patient, we were not even thinking of a red degeneration. However, axial MR showed hemorrhagic changes in the leiomyoma, and these changes were seen as hyperintense signal on T1 weighted images, and the signal was variable on T2 weighted images with low signal intensity RIM due to the shortening effect of deoxyhemoglobin, intracellular methemoglobin, or hemosiderin of blood products, which was confined to the thrombosed blood vessels. Now, in these leiomyomas, normally there is thrombosis of the peripheral blood vessels that occurs. So the peripheral high signal intensity, which is seen as a low signal intensity rim on T2 and as a high signal intensity rim on T1 weighted images due to shortening effect of methemoglobin of blood products, which is confined to the numerous thrombosed dilated vessels which surround the tumor. So we should be picking up these red degeneration or the carneous degeneration of leiomyomas better picked up on MR. This was another case of a 45-year-old woman having uterine leiomyoma with red degeneration. On the fat saturated T1 weighted image, we can see a peripheral high signal intensity rim, which is clearly seen surrounding the leiomyoma, and the leiomyoma itself is showing ISO to slightly high signal intensity. Now the same thing is seen as a hypo-intense or a low signal intensity rim on T2 weighted images. And sometimes they say that these leiomyomas, they are themselves hypo-intense. So these rims are better seen, even better seen, or they are more prominent on susceptibility weighted images than on T2 weighted images. So classically, any leiomyoma which is showing a peripheral hyperintense rim on T1 and a hypointense rim on T2 with the background of abdominal pain should be thought of as a red degeneration, even if the patient is non-pregnant. So this was a case of a complicated leiomyoma. Another case of benign uterine anomalies. This MR shows diffuse adenomyosis of the uterus. This is a T2 weighted sagittal MR of the uterus. This is a broadened junctional zone. We can see that the junctional zone is wide. It is more than 12 mm, and there is poor definition of the endomyometrial junction. This is blurred as compared to this normal T2 sag of a uterus, in which we can very well see the well-defined endomyometrial junction. And the third image shows the sagittal image of a patient with focal adenomyosis of the uterus. And in this, we see that the fundus and the posterior uterine wall is thickened due to marked broadening of the junctional zone. And hyperintense foci, they were seen, these T2 hyperintense foci, they're classical of adenomyosis. And they were seen as T1 bright structures also on T1 weighted images. So this is diffuse adenomyosis, and this is focal adenomyosis. It is very important for the radiologist to pick up these also. And nowadays, with advanced treatments by radiologists, the focal adenomyomas, they are being treated with high intensity focused ultrasound treatment, in which they cause pass high intensity focused ultrasound beam through these focal adenomyotic areas. Diffuse adenomyotic myosis is not treated. However, focal adenomyomas can be treated with high FU and cause necrosis of these areas, and hence they cause over a period of time, they cause fibrosis and shrinkage, and these patients can be saved from saved with non-invasive modalities like HIFU. Now coming to, after the benign uterine masses, coming to uterine sarcomas, a 69-year-old female presented with intermittent chronic pelvic pain. Her CA 125, CA 19.9, and CEA were normal. And on T2 sag, we could see a circumscribed unilocular cystic mass, which was about 6 into 5 centimeters within the posterior myometrium. In the posterior myometrium, it was extending into the rectouterine space. It showed T2 hyperintense signal and T1 hypointense signal. And in addition, on the right lateral wall, within this cystic mass, there was a solid component. And this solid component was showing intense diffusion restriction. I'll see if the video works. Yeah, we can see the mass how it is within the posterior myometrial wall. In this image, we can see that the uterus is being pushed anteriorly. We can see the endometrial lining of the uterus and the presence of this mass within the posterior myometrium. Another T2 heterogeneous intermediate unilocular cystic lesion with irregular margins is seen in the left hemipelvis, abutting the uterus. And this mass, it was very interesting because this mass was also abutting the rectosigmoid. Here you can see the left-sided mass was abutting the rectosigmoid, and the rectosigmoid had multiple colonic diverticuli. See these small outpouchings with the from the rectosigmoid, and we can see there is some surrounding fat stranding also, and there was no pelvic lymphadenopathy. And this left-sided mass was a diverticular abscess due to these diverticuli. The patient was an elderly patient, and in addition to the uterine sarcoma within the uterus, the patient also had a abscess in the left hemipelvis due to diverticulitis, and multiple outpouchings can be very well seen from the rectosigmoid in these videos. Now the unilocular cystic mass along the posterior uterine wall, it showed in mild diffusion restriction within the solid component as seen by bright signal on diffusion, and which is dark on the ADC map. However, the diverticular abscess, it had irregular margins and it showed intense diffusion restriction, just like you see in abscesses. And here we can see in these post-contrast images that the unilocular cystic mass in the right hemipelvis, that is showing solid enhancing component, this solid enhancing component. This is the above three images are T1 pre-contrast and the lower are the post-contrast. So we can see how intense enhancement of the solid component is within the sarcoma, and the diverticular abscess is showing peripheral post-contrast enhancement. So the final diagnosis came out to be uterine sarcoma of the intrauterine lesion and of a pelvic abscess due to diverticulitis of the left-sided, left hemipelvis lesion, which was showing intense diffusion restriction. Now, a short word about malignant uterine sarcomas. Malignant uterine sarcomas have been broadly divided into mesenchymal or mixed epithelial and mesenchymal origin. Mesenchymal can be leiomyosarcomas when they are of smooth muscle origin, and when they are of endometrial stroma and origin, they are endometrial stromal sarcomas, which can be of low, high grade, or undifferentiated. And mixed epithelial and mesenchymal origin are adenosarcomas. So, Figo staging system for uterine sarcomas tells that when the tumor is extending beyond the uterus, it is stage 2, and when it invades the abdominal tissues, it is stage 3. And these, we have to remember that as radiologists, we need to give the staging. However, we should also remember that these uterine sarcomas, they frequently exhibit early peritoneal and hematogenous spread with distant metastasis instead of spreading locally in the pelvis and to the lymph nodes as carcinomas do. You've seen so many cases of endometrial cervical carcinomas in your these series. And in these sarcomas, we should be having an eye for peritoneal deposits while we are reporting the MRs, as these tend to have these intraperitoneal and hematogenous spread. So the key points in evaluation of sarcomatous uterine lesions is that in the early stage of uterine leiomyosarcomas, it can be well circumscribed, while if they are more advanced, they can be irregular. And also we should know that the depth of myometrial invasion is important in substaging stage 1 adenosarcomas when they are limited to the endometrium, it is stage 1A. When it is invading less than half of the myometrial thickness, it is stage 1B, and 1C is more than half of myometrial invasion. And now this was a companion case of a 56-year-old woman in which this uterine mass was a leiomyosarcoma, and the sagittal T2 weighted image shows a heterogeneous myometrial wall mass with necrotic areas. And this is showing intense post-contrast enhancement. These are the lower ones are the post-contrast T1 sections in the coronal and in the axial and coronal planes. The upper one is Sag T2. So the necrotic areas and the presence of these intense enhancement in the solid areas, which were showing diffusion restriction, these all point towards a neoplastic etiology, which is malignant, towards a sarcomatous change in any case of leiomyosarcoma. In any case of when you have to differentiate leiomyoma from a leiomyosarcoma. And this was still another case of a leiomyosarcoma in a 43-year-old woman that I recently saw. And in this, I could see a subserosal tumor, a subserosal tumor, like we see a subserosal leiomyoma. This was predominantly necrotic, and it was arising from the uterine fundus on Sag T2. The peduncle is well seen. And on coronal also, I can appreciate the peduncle, and multiple other uterine fibroids were seen in addition, and both the ovaries were normal. This is one ovary, this is the other ovary. And the necrosis and the presence of these multiple locules and thick septae, solid component, which was showing diffusion restriction, bright on the B800 and dark on ADC mapping. This was pointing towards the sarcomatous etiology. And on post-contrast, these were showing the thick septae and the solid component, these were showing intense enhancement, and it came out to be epithelioid leiomyosarcoma on surgery. So all these pointers although the patient had multiple other leiomyomas, this one was sarcomatous. So the presence of necrosis, hemorrhage, large size, and advanced patient age, diffusion restriction, intense post-contrast enhancement of the solid component, these should all give us a lead and make us suspicious about the presence of sarcomatous change in these myometrial leiomyosarcomas. And this was still another case of a leiomyosarcoma in a 55-year-old woman, in which in this T2 weighted image of the pelvis, we can see that there is marked uterine enlargement, and there is myometrial tumor, which is necrotic. And there were these lung metastases and mediastinal enlarged lymph nodes. And on the gadolinium enhanced images, we could see that it showed early intense peripheral enhancement with irregular central zones consistent with necrosis. And on diffusion weighted images, again, we could see that it showed restricted diffusion in the solid areas. These solid areas, they are bright on diffusion and dark on ATC. So again, the presence of necrosis, diffusion restriction, and early intense post-contrast enhancement favors leiomyosarcomas. And as I've already told, they have a propensity for hematogenous metastasis, as seen in this case. And we can see lung metastasis and mediastinal lymph nodes. And there was no pelvic lymphadenopathy, however, in this case. So in this article in AJR, it was very nicely described the MR characteristics of leiomyosarcomas on multiparametric MRI, covering all the points that we have discussed. And the margins in leiomyosarcomas, as opposed to leiomyomas, are often ill-defined, infiltrating, and the shape is irregular, and the signal intensity on T1 and T2 is heterogeneous and can be hyperintense on both T1, T2 due to hemorrhage. And the enhancement is again heterogeneous due to presence of hemorrhage and necrosis. There is usually restricted diffusion, and ADC map also confirms the low ADC values. So this multiparametric MR approach should be followed while differentiating leiomyomas from leiomyosarcomas, although radiology is not always 100%. And sometimes you have to take the support of histopath only. But as a radiologist, we should be suspecting these as early diagnosis, and our correct report is important. And multiparametric approach of MR helps us in zeroing down the malignant etiology. So coming to the next spectrum, that is acute and chronic pelvic pain disorders. My first patient is a 22-year-old female who came with intermittent pain abdomen. And in this patient, the ovary showed enlargement and there were peripherally placed follicles, and all I could think of was torsion. However, the gynecologist, as the patient was again a staff patient, and the gynecologist was not feeling that it was that tender, as she was having chronic pain for the past few days. She ordered for a subsequent MR, and as the belief of the gynecologist was that it is not that convincing for torsion. However, T2 weighted MR showed typical features of adnexal torsion, and we could see an enlarged ovary with peripherally located, with all these string of pearls kind of follicles. And in addition, there is this presence of pelvic free fluid. And we could also see that the T2 weighted MR images showed a thickened heterogeneous pedicle, and this pedicle was twisted. Now, whenever you're suspecting torsion, you should always look for this pedicle. This vascular pedicle can appear as elongated or edematous heterogeneous tube-like tubular structure that lies between the uterus and the ovary. The uterus and the ovary intervening area should be searched for this pedicle, because it always helps in confirming the diagnosis of torsion on ultrasound as well as on MR. So this is called the whirlpool sign. When this pedicle twists, and it is present in more than 90% of confirmed cases of adnexal torsion. So, and it supports the diagnosis of torsion. So this was the whirlpool sign and the thickened vascular pedicle on MR. And on the T2 SAG image, the above image, we can see free fluid in the pelvis. And on diffusion weighted images, the torted ovary was showing patchy diffusion restriction. And the presence of free fluid again goes in favor of torsion. And on post-contrast images, patchy contrast uptake was seen in the torted ovary. The patient was immediately taken for surgery. However, it was a chronic kind of a problem, and the ovary could be salvaged. They could detort the pedicle and salvage the ovary. And so while approaching these cases, we should always remember the schematic diagram of the ovaries that has been nicely given in this article of Radiographics last year. And we can see that the image shows normal relationship of structures, and we can see that there are three kinds of ligaments. One is the suspensory ligament, which contains the ovarian artery and the vein. Two is the broad ligament, and three is the ovarian ligament. And on this side, the authors have depicted that how these relationships change in the setting of adnexal torsion, with the twisted pedicle consisting of the suspensory ligament, the fallopian tube, and the ovarian artery and vein, which get twisted within this torted ovary. So the ovary itself enlarges and gets congested. So while reporting these torted ovaries, we should again always look for ovarian edema and all on ultrasound itself, because it is a medical emergency, and presence of enlarged ovaries more than 4 centimeter, ovarian edema, variable echogenicity is often seen. The ovary may be hypo or hyper-echogenic depending on the amount of ovarian edema. The follicles are peripherally placed, and the ovary itself has moved from its location and is now more midline. And the presence of whirlpool sign of twisted vascular pedicle should always be looked for and is seen in up to 90% of cases. And an underlying ovarian lead lesion like a follicular cyst, a hemorrhagic cyst, a dermoid commonly, which are the possible lead points for torsion, should always be looked for. The ovaries normally tender to transducer pressure in these cases, and the presence of free fluid also is an ancillary finding, which is seen in more than 80% of cases. So in these ultrasound findings should be always looked for, and we should always remember these key points, because for the patient it is very important that her ovary is safe. The presence of an enlarged ovary more than 4 centimeters, a distended pedicle, surrounding fat stranding, edema in the ovary, free fluid, and the presence of a lead mass, these are always pointers towards ovarian torsion, as Doppler is often not helpful, and Doppler in torsion is very, very variable. Sometimes it may not show venous flow, it may show little venous flow. Sometimes it may show absent arterial flow, which is less common and is a sign of poor prognosis. And the presence of venous flow is the first and foremost thing that should be looked for, as it is the first thing to be affected in torsion. And this absence of venous flow has a sensitivity and specificity, both of which are close to 100%. And the absence or reverse diastolic flow can also be seen when you see the arterial flow within this mass. However, we should remember that normal vascularity doesn't rule out intermittent torsion. And normal Doppler flow can occasionally be found in these patients due to dual supply from both ovarian and uterine arteries. So this was another case of torsion in which the lead point was a teratoma in both the cases. In the first case, it was confirmed on MR, and in the second case, the ultrasound itself with a tooth-like structure, it gave the diagnosis. So practical points, again, I'm repeating, the ovary should be tendered to transducer. The absence of ovarian Doppler flow is highly specific for torsion, but normal Doppler flow doesn't completely rule out torsion, and an ovarian mass causing the torsion should always be sought for. Now, this was another young woman that we saw recently that had this large cystic mass as a lead point for torsion. We can see that the ovary is dotted and it is showing these peripherally placed follicles. And this was a lead mass, and this ovary has got torted and twisted from the left side and reached the right side. And this black arrow which I've shown is pointing towards the normal right ovary, which is there in the right hemipelvis. So the ovary which gets torted often moves away from its location and has peripherally placed follicles as shown. And this was the vascular pedicle that we could see associated with this that I've already talked of. So features suggesting non-viability are a lead mass with eccentric or irregular wall thickening, absent central vascularity on Doppler, and stromal hemorrhage, which is seen as high signal intensity on T1 and intermediate or low signal intensity on T2 weighted images, and absent enhancement on MRI. So coming to benign ovarian masses and their characterization. After these emergency conditions, coming to other benign ovarian masses, and then how to characterize them on ultrasound and on MRI if required. So the first patient is a 33-year-old patient which came with acute pain and tenderness in the lower abdomen, and she was detected to have a left-sided adnexal mass. Now on ultrasound, this lady, she showed a cyst which had the typical appearance of a hemorrhagic cyst, which with an avascular echogenic component along one wall, and this was having angular or concave margins, suggestive of a retracted clot. So we thought that maybe this is a hemorrhagic cyst, and as the patient, she was a resident in our department, she underwent a cross-sectional imaging MRI on her own self, and she was found to have this T2 hyperintense hemorrhagic cyst with this formation of this fluid level, and this was a retracted clot that you could see on ultrasound. So these were the sagittal images showing the opposite ovary is normal, the uterus is normal, and this is the left-sided hemorrhagic cyst with fluid level seen as hypointense level with hyperintense contents and the retracted clot. These are the classical MR pictures, and this was confirmed further on T1 weighted images when the lesion was found to have T1 hyperintense contents, which did not show any suppression on the T1 fat set images. T1 fat set are the lower row, and T1 non-fat set are the upper row, which show that the mass is hyperintense with fluid levels with this retracted clot like or a soft tissue like structure within this. So these are the T2 axial images, which are better showing the cystic structure in the left hemipelvis with this hypointense T2 internal content with the formation of a fluid level also, and the opposite ovary is normal, the uterus is normal. Now this showed minimal diffusion restriction. The hemorrhagic content showed minimal diffusion restriction, and there was no enhancement of this structure on post-contrast images. These are the post-contrast T1 images, which showed only thin peripheral enhancement. Now, the teaching point in this case is that this hemorrhagic cyst was nearly 5.2 into 5 centimeters in size. So final diagnosis of hemorrhagic cyst was given, which was labeled as an ORADS MRI 3 mass. Now, hemorrhagic cysts of less than 3 centimeters in a premenopausal woman, they are labeled as ORADS 1 on MRI. However, as this was little more than 3 centimeters and was close to 5.2 centimeters or so, so it was labeled as ORADS 3, and the patient was kept on follow-up. So ORADS 3, why it was labeled as ORADS 3? Because it was unilocular. It had hemorrhagic content. It had a smooth enhancing wall. There was no solid enhancing tissue. So it was labeled as ORADS 3. So if you go to Google, like normally we do not remember the ORADs by heart. So what I find very user-friendly and convenient while reporting these cases of ovarian masses in which I need to give ORADs who are not high-risk cases. In those patients, we normally give ORADs. So there is an ORADs MRI calculator when you put on the net. So on going to the ORADS MRI calculator, you come with the questions like this, presence of peritoneal mesenteric nodularity, is the hemorrhagic, is there are the cyst hemorrhagic or follicle, is there fat within the lesion, is there enhancing solid tissue associated with the adnexal lesion? And like this, you get a series of questions and you just have to keep clicking yes or no. So in this mass, while going through these series of questions, in the end, you get an ORADS, and the system itself calculates the ORADS, and this is very user-friendly and can be done on your phone itself. So go through these questions and pick the cyst type. You mark the wall enhancement. Is the mark tell the system if the fluid content is simple or endometriotic, and the system pops out with this that it is an ORADS 3 score and that the cyst is unilocular because it has hemorrhagic fluid, has smooth enhancing walls, and no enhancing solid tissue. So the purpose of bringing out this case was to teach you about the online MRI calculator, which is very convenient, and just with these series of questions, you can reach the diagnosis. So this is a very common scenario that we come across, that we get bilateral ovarian masses, and in these cases we have to give separate ORADs for both the masses. Now this patient was a 32-year-old woman for whom MR was performed for lesion characterization after bilateral adnexal masses were seen on ultrasound. So first image is axial T1 non-fat SAT. This is T1 fat SAT, and this is axial T2 image. So in the axial T1 image, we see bilateral ovarian masses which are showing a higher signal intensity. Now, in this image, we'll first go to axial T2 weighted image. In the axial T2 weighted MR image, we see that the low signal intensity of the right ovarian mass is seen. This is due to blood elements. Now first we will see how the right-sided mass behaves. This is hyperintense on T1 and is hypo on T2. So this likely has blood degradation products, and this phenomena is referred to as T2 shading when it is hyper on T1 and is hypo on T2, and this is typical of endometriosis. So the right-sided mass was diagnosed as an endometrioma, and if we see the left hemipelvic mass, we see that it is hyperintense on T1 fat SAT, but shows suppression on T1 fat SAT images. So hyperintense on T1 non-fat SAT and hypo on fat suppressed. So it is clinching the diagnosis of a fat containing mass that is a mature cystic teratoma. So the final diagnosis was given as a mature cystic teratoma of the left ovary and endometriosis of the right ovary. So while calculating ORADs, though there is these classical descriptors on MR are very easy to pick. Again, I'm repeating, you can go to the MR calculator and reach a diagnosis. Like in the first, in the case that I have shown, the right-sided mass is a unilocular cyst with simple or endometriotic fluid content with a smooth enhancing wall and no enhancing solid tissue, while the left-sided is a lesion with lipid content and it had no solid enhancing tissue. So it was given as mature cystic teratoma. So always try to report as per the ORAD system in the ovarian masses in women who do not have a high risk, do not have a family history. And in these women, it is always good to give a risk stratification and always report the developmental anomalies as per the ASRM and the ESHRE system. So this is one thing that I'm again stressing upon before moving to the next case. And in leiomyomas, do look for malignant change on multiparametric MRI. And in torsion, look for the twisted pedicle sign, the whirlpool sign, whenever you're suspecting a case of torsion. Look for ancillary findings like free fluid. And also in these patients, because you need to diagnose on ultrasound, do not rely on Doppler images, or as Doppler can be fallacious in cases of torsion. So now moving to the next spectrum of cases. So this was a very interesting case. She was a 34-year-old woman who underwent hysterectomy in a peripheral hospital. She had a severe PPH following childbirth, and thereafter, we do not have any record of her hysterectomy. And when she came to our institute, about a year or so later, after her previous hysterectomy, she had now current complaints of fever, pain, and foul-smelling vaginal discharge. And on the T2 weighted sections, we could see that there was a circumscribed multilocular T2 heterogeneously hyperintense mass, which was about 5 into 4 centimeters in the left adnexal location, and the left ovary was not seen separately. And the stump was healthy, and this was the right ovary. This was the right ovary, which was stuck to the stump. And the left-sided ovary was also pulled towards the stump, and the left-sided ovary revealed this multilocular T2 hyperintense circumscribed mass. Now, this multilocular left-sided lesion was also T2, not only T2 heterogeneously hyperintense, this was also hyperintense on T1 weighted images. And one of the locule showed macroscopic fat within this. Now, this macroscopic fat pointed that it was likely a teratoma. And as we could not see any solid tissue on T1 weighted images, and there was this fat suppression within one of the locules of the left-sided adnexal mass, the diagnosis of teratoma, mature cystic teratoma was made. And the right-sided mass, it also showed intermediate signal intensity on these T1 weighted fat set and non-fat set images, and there was no suppression on the fat set images in this right-sided mass. So these were the sagittal sections of this patient. Yeah. So these are the sagittal sections that were very interesting, and these sections, these serial sections, show that the vaginal stump is healthy. The uterus is not seen consistent with status post hysterectomy, and this left-sided mass, it seemed to have, in this image where I am pausing, we can see this connection of the left-sided multilocular mass with the vaginal wall. So this left-sided multilocular mass was closely abutting the vaginal vault, and this vaginal vault was also focally indistinct at its apex. And there seems to be communication between the left-sided mass and the vaginal. So it is better seen on these still images, which I have pointed here. It is seen in these still images. The left-sided ovarian mass is stuck to this, and there seems to be a communication between the vaginal vault and the left hemipelvic mass. And these were the T2 coronal images. And these were showing how both the adnexal masses, they were stuck to the vaginal vault, and the left-sided mass was heterogeneous multilocular, and the right-sided was an ovary with a cyst that was hyperintense on both T1 and T2. So one of the locules of the left-sided mass showed intense diffusion restriction, like you see in infected cases like in abscesses. So this pointed out that this fat-containing multilocular mass had probably got infected, and this was, after infection, this was like leaking out through its connection through the vaginal vault. And that is why the patient was complaining of a foul-smelling vaginal discharge also. So this was a teratoma that had that macroscopic fat content that was showing fat suppression. And also, this was a teratoma that had got infected and had developed a fistulous communication with the vaginal vault. So this fat content of the mass led to the diagnosis of a teratoma, and the diffusion restriction that was intense, that led to the suggestion of intense the restriction led to the diagnosis of infection within the teratoma and a fistulous connection with the vaginal vault. And there was septal as well as peripheral post-contrast enhancement within this left-sided mass. So this was a case of an infected dermoid. So it was a macroscopic fat-containing multilocular mass on the left, likely a mature cystic teratoma with secondary infection, which is very, very rare. It is very rare to see teratomas undergo infection. And there are some this was the histopath of the patient. The patient was managed with laparoscopic cystectomy, and as she was a young patient, the remaining ovarian tissue was preserved and the right ovary was also preserved. And the histopath revealed a mature cystic teratoma with abscess formation. So, though mature cystic teratoma is a prevalent ovarian neoplasm, the incidence of infection in a dermoid is very, very rare, less than 1%. And factors that can lead to infection are IUD, DNC, and surgery. So another case of infected dermoid that I saw recently was that of just a 16-year-old female. She was transferred to our institute with 5 days of fever and abdominal pain, and she revealed tenderness in her pelvis and right iliac fossa. First, when she came to the emergency, an X-ray was done, and there was this calcific structure seen in the pelvis, which was thought of as maybe a ureteric stone. And then the patient was sent for ultrasound, and transabdominal ultrasound of pelvis in the axial plane showed the multilocular cystic lesion in the right adnexa with echogenic contents in one of the locules, showing posterior acoustic shadowing. So this was a case of a dermoid. We can all pick this up on ultrasound itself. These echogenic contents and this posterior acoustic shadowing coming through one of the locules showed that this was maybe a calcific component to it. On Doppler, there was moderate peripheral and septal vascularity in this mass. And subsequently, as the patient was having a lot of pain in the right iliac fossa region, she was thought to have maybe a coexistent appendicitis also in addition to the dermoid. A CT was ordered for, which showed a large right adnexal lesion. This was a right adnexal mass with multiple thick enhancing septae and internal tooth-like hyperdense contents, and also multiple air foci within this mass. The mass was seen to abut the rectosigmoid, and in addition to this mass, we could see multiple peripheral enhancing collections in the right hemipelvis and within the infracolic compartment in the right paracolic gutter also. So we thought that maybe this is a dermoid which has got ruptured, and maybe it has a bowel communication because it has these air foci within it. Again, a very, very rare scenario of having a dermoid which has got a connection with the rectum and hence got infected and further got ruptured into the peritoneal cavity, leading to peritonitis. So these were the axial CT scans sections of the patient, which revealed multiple peripherally enhancing collections within the subhepatic location, within the infracolic gutter, within the infracolic and right paracolic locations, and multiple collections are well seen in the CT. And as we go further down into the area of concern, which is the pelvis, we come across that these collections, they are communicating with this multilocular cystic mass, which has now appeared, which has these air foci and this tooth-like structure suggestive of a dermoid. So to confirm the diagnosis, and these are the reconstructed CT scans showing this tooth-like structure within the air-containing dermoid. The air is due to likely its connection within the rectum. And this connection was better confirmed on MR, because on CT we did not give any rectal contrast as the patient was very sick. So in this MR, we can see multilocular cystic mass in the right hemipelvis, and we see that the right ovary is not separately seen. And this mass shows heterogeneous T2 hyperintense signal intensity. And we can see multiple pockets of intercommunicating pockets of T2 hyperintense collections in the right iliac fossa and the infracolic compartment. So this multilocular cystic mass has these hypointense foci, and this area of signal loss likely due to the calcific component. So these were the collections that I've marked with the arrow, and this was the an important section that showed us two good connections, and focal discontinuity of the mass could be discerned with the rectum posteriorly, and also a rent could be seen along the anterior wall of the lesion on sagittal images. So the mass had this fistulous communication with the rectum. So this dermoid had developed a rectodermoid fistula over a period of time and had got infected, and hence had leaked into the peritoneal cavity. So these were the T2 sagittal images. In these images, we can see that how beautifully the focal discontinuity of the posterior mass with the rectum is well seen, and how it is here in this section, it is going into the anterior collection and is subsequently going into the right paracolic gutter through the right iliac fossa. So this was a case of this dermoid, which was a multilocular heterogeneously hyperintense T2 mass with tooth-like structure, well seen on CT, which had developed this rectodermoid fistulous connection. And this rectodermoid fistulous connection, as I've shown through the arrow, has never been reported in literature. And we can see that the normal uterus is there, which is anteverted and is showing normal junctional anatomy. And we can also appreciate the surrounding inflammatory changes, fat stranding, and intralesional fat component on these T1 weighted non-fat sat images in the upper row and T1 weighted fat sat images in the lower row. And these arrows are pointing towards the corresponding foci, which are hyperintense on the T1 non-fat sat images, and they are showing signal loss in the lower row in the T1 fat sat images, showing areas of intralesional macroscopic fat. So all these gave us a pointer towards this fat containing lesion, which had that tooth-like structure, which was a dermoid. And on diffusion, there was intense diffusion restriction, and surrounding inflammatory changes was seen. And this was diagnosed again as an infected dermoid based on the presence of intralesional fat and intense diffusion restriction. So on post-contrast images, as expected, it showed peripheral wall enhancement as well as septal enhancement, and all the collections also showed these enhancement patterns of the walls. So the findings were of a secondarily infected ovarian teratoma, and this teratoma had led to peritonitis with multiple small collections due to chronic leakage of dermoid cyst, which is a lifetime case again, and this patient was managed surgically with repair of the rectodermoid fistulous communication. And she's currently doing well. So this was I end my talk with infected ruptured dermoid to show you a very, very rare case. And now I come to a few spotters because there are only last 10 minutes of the talk left now. These spotters I have kept for you to answer in the chat box. To kindly take them as exam spotters, because in the exams you get spotters and you do not get options of polling and all, na? Like you get in multiple choice questions. So in these spotters, I have shown you only classical cases. So this is the first case of a female who had acute pain abdomen. And I request Sarita to kindly put the answers on the chat box.
Yeah, sure, ma'am.
So as pointed out by this woman's history, yeah, most of you are picking it up right, that it is a case of an ovarian torsion, and a left ovarian torsion is what I need you guys to pick up, because the ovary has got torted and we can beautifully see the twisted ovarian pedicle, which I've talked of in my talk, which is leading to the ovary, and the peripherally placed follicles in the ovary. So coming to the next spotter. He was a case, a young woman who had got operated 3 years back for endometriosis and was on follow-up. This time she came for her MR, and I've just put in the relevant some sections of MR here. So any answers? Sir, Shweta?
Yeah, ma'am, posted, ma'am.
Okay. So this was, you will not call it deep infiltrative endometriosis. Somebody has written deep infiltrative endometriosis. That is a totally different entity. So this is a case of an endometriotic deposit in the anterior abdominal wall on the left side where she was operated upon. And this is a case of a scar endometriosis. You can see this irregular T2 heterogeneous hypointense mass with these speculated margins and these interspersed T2 hyperintense areas. So this was a case of scar endometriosis and should always be thought of in the patient who has a history of endometriosis. So coming to the next case. So this is a good exam practice that I'm giving you. So kindly put the answer, Sarita.
Yeah, ma'am. She's posting in the
Very
Zoom chat.
smart. I've even discussed this in my talk if somebody has listened it. Okay. So some answers are saying unicornuate uterus, and one or two answers are saying right-sided hydrosalpinx. So this is a classical case of unicornuate uterus. There is no hydrosalpinx in this case. And if you see, like in this case, there is this banana-shaped uterus, and from the cornu of the uterus, you can see that I'll show you. This is a banana-shaped uterine cavity. There is this fallopian tube which is very much normal, and this is not dilated to call it hydrosalpinx, and we can see a spill from this, and we cannot see the other cord. So this is a classical unicornuate uterus. So this is the next case. I'm sorry for my bad throat. So and this was an easy one. Most of you have answered it correct. So this is a case of a mature cystic teratoid. It is a dermoid with fat and calcific or tooth-like foci within it. On CT, it is very pretty easy to diagnose. So coming to the next case. So this woman underwent an X-ray for complaints of pain of the abdomen. And yes, this is a calcified fibroid. Excellent. Great. So this was a very easy one. And now I show you the next case. So okay, take this image for the next case. So any answers, Sarita? So the complete diagnosis of this case is a partial septate uterus. There are variable answers to this. Somebody is saying a bicornuate uterus. Somebody is saying a septate uterus. Others are calling, yes, there are some answers saying by partial septate uterus as well. So the correct thing is it is not a bicornuate uterus because this is only a slight indentation to the fundus. The fundus has an indentation of more than 1 centimeter for it to call a bicornuate uterus, number one. Number two, there is an internal indentation of more than 50% of the uterine wall thickness. And we can see that this has an acute angle to it. And this is classical for a septate uterus. And the external contour, once it is normal, you never think of a bicornuate uterus. So this is a partial septate uterus because it is not extending up to the internal os. So once you see a septate uterus, see if it is partial or complete. The second thing is to see what are the constituents of the septum, whether it is muscular or whether it is fibrous. In this case, it is a muscular constituent. So this is a partial muscular septate uterus. Okay. So we go to the next case. Now, you might have covered this in the previous talks. In the last series, I myself took a talk on these kind of problems. Okay. So Manish Jha has replied, diadelphus. Somebody has written bicornuate also. So this is a diadelphus uterus because we can see two widely splayed uterine horns with separate cervices here and with separate vagina as well. So this is a diadelphus uterus. And this is the last photo for today. And we finish well in time. Usually in exams, you don't get history. I've given you history in all the cases, which provides you lead. In exams, you get just the spots. That's it. You have to diagnose the anomaly. So one of you have written focal adenomyosis, the other have written degenerated fibroid. Third has again written posterior adenomyosis. Manish has written adenomyoma. Somebody has written leiomyosarcoma as well. Okay, so there is a wide variety of diagnosis, most of them being focal adenomyosis, which is the correct diagnosis. This is a posterior wall adenomyosis, and we can see T1. This is T1. I've given a lead here at the corner also. This is T1, non-fat set image, which is showing multiple T1 hyperintense as well as T2 hyperintense intralesional cystic areas, classical for look like I had shown you. They have cystic areas and different kind of hemorrhagic areas with solid tissue. And degenerated fibroid again has a different look. It will not show an indistinct junctional zone or such like interspersed T1 and T2 foci. These are diagnostic for adenomyosis only, focal adenomyosis with adenomyoma formation in the posterior wall. So this is a spotter, and do not confuse it with sarcomas and fibroids. Okay. So that is the end of my talk, and I'm happy to answer any queries that the audience has got. Thank you very much. So we put the puzzles together. I've shown you a variety of congenital cases to acute emergencies to infected dermoids, and I've shown you how to approach cases using MRI calculators for ORADs. So I welcome you all to post any questions that you have, and thank you very much for your kind attention.
Thank you so much, ma'am. That was an amazing cases and very rare. You have covered almost a lot of cases of women series, imaging cases. So we have a lot of questions on in the case 1, like how to differentiate ACUM from a degenerating fibroid on ultrasound. Does the age is helpful to differentiate the both?
ACUM from a degenerating fibroid is a very straightforward diagnosis, number one. I'll see if I can go back to the presentation and show you that case itself. See, in a degenerated fibroid, number one, now the common thing is that both things can be intramyometrial. While in an ACUM, normally you see the layered appearance, that this layered appearance of endometrium lining the ACUM and the junctional zone and then the myometrium and then the position of this ACUM just under the round ligament. Now, all these things put together, they are diagnostic. In this case, like here in this image, we see that the position was just inferior to the round ligament attachment at the cornu. And in the image that we see on the right, we can see the endometrial lining, the T2 hyperintense endometrial lining, nicely lining the acum. And we can see that the junctional zone is there, which is widened. And this junctional zone, why is it widened? Because again, it is a sort of a mass that is bleeding into itself, like we see in adenomyosis. So in acums, they are commonly associated with trilayered appearance, widened junctional zone, adenomyosis of the surrounding area, and intramyometrial location inferior to the round ligament. So all these things, they are pointers, and they should lead you to suspect acum. Acum has to be removed surgically.
Okay. So someone asked why it is not proteinaceous content in acum. Maybe it's a T1 bright signal they were asking.
See, it can be proteinaceous also. T1, T2 bright can be proteinaceous. Of course, we know that both are bright, T1 and hemorrhage are bright, and it can be proteinaceous also.
Yeah.
It is very difficult on MR. T1, T2 bright is always taken as both proteinaceous and hemorrhage.
Okay. So how to see cornua on MRI in the case 1?
How to see cornua? Here, in this image, I've put both the cornua, which I've put in and marked with the arrows. This is the way to look for cornua on MRI. You can see both the cornua very nicely in MRI, and they should always be looked for because you do come across cornual pregnancies, and sometimes you need to diagnose unicornuate uterus also, in which you see only one cornua, not both the cornua. Okay, so here in this case, and in the last image also, we can see the cornua.
Yes.
I'll see if my video works. I'll show you the cornua all the more better. I'll see if this image works, this video works.
Yes.
So just keep on following the uterus and then see, look for both the cornua in a normal uterus. I'll say in this here where I'm showing you, you can see both the cornua. The one in the one cornua, there is this G-sac on one side, eccentric G-sac, and the other cornua is compressed and is seen very nicely.
Yes.
So there is no doubt in the cornua. Okay. And you here in these contiguous images, you can even see the acum so beautifully.
Yes.
With the hyperintense endometrial lining, the widened junctional zone, the indistinct endomyometrial interface. And see, all around it, it is like adenomyotic changes, while the normal uterus is having a nice distinct junctional zone and a sharp endomyometrial
My
interface.
question
Okay?
is round ligament normally seen on MRI?
Yes, it is normally seen, and it is beautifully seen in this T2 space sequence. See, look on both sides. Yes, once you start looking for it, you start seeing it. A round ligament can be very well seen.
So
Yes.
Next question, please show suspensory and broad ligament in MRI, on normal MRI.
On normal MRI, you don't see broad ligament and suspensory ligaments. You see them if they are twisted in the pedicle. You see a twisted pedicle, which you need to look for in between the ovary and the uterus. That is the way to go.
Okay.
You don't see broad ligament. You know the location of the broad ligament, but you don't see the ligament as such. Now, see in this case of acum also, you can see the trilayered intramyometrial lesion, which is very different from the normal leiomyomas. Will not be a cystic mass like this. They're usually T2 hypo, and they are never trilayered. Okay. So I hope I'm clear.
Yes, ma'am.
And yes, this is a very close differential diagnosis
Mhm.
of a rudimentary horn.
Ma'am, the next question, is it important to give classification for the Mullerian anomalies?
Yes, it is very important to give classification
Okay.
because it keeps us all on the same platform. We all know what we are talking of, okay? And this recent ASRM classification that I'm showing in the slide, this is very nicely given in this article. Please refer to this article, okay?
So how to decide muscular and fibrous septum in case of septate uterus?
That is by the intensity. Muscular will have isointense to the myometrium and fibrous will be hypo to the
Myometry.
myometrium. Yeah,
Yes.
onto-weighted images.
So regarding the ovarian torsion case, how to differentiate a vascular pedicle from edematous fallopian tube?
On
The vascular pedicle
which
from
modality they
edematous
are asking.
fallopian tube.
No, which modality they are asking. On Doppler, it is very easy. You can put in color. You normally find vascularity in such cases. Okay. Now, from an edematous fallopian tube, you don't see,
MRI.
once you see the follicle, once you see the ovarian torsion, normally you don't. Why do you need to first of all distinguish it from the edematous fallopian tube?
Mhm.
I don't understand the question, frankly.
Yeah, yeah. So sometimes
You can answer, Dr. Rajni, if you understand it. I somehow not able to
I think
make
we
out.
have to follow the sequences
Yeah,
and we can differentiate.
yeah, yeah.
Yeah. Ma'am, another question, how to differentiate leiomyosarcoma from, one second, uterine sarcoma? Is it possible
So
to differentiate?
leiomyosarcoma is a spectrum of this only. Na? I've shown you these
Yeah, we have to.
leiomyosarcomas are mesenchymal tumors which are of smooth muscle origin. So uterine sarcomas are further divided into those of smooth muscle origin and those of endometrial stroma and related origin. Those of smooth muscle origin are leiomyosarcomas, while the others are endometrial sarcomas. That is all.
Yes, ma'am. Last question. In a 4 centimeter ovary, suspecting torsion, flow is seen on Doppler. But if patient is normal, how to rule out torsion if ultrasound is not there? Maybe they will
Maybe
enlarged ovary with normal flow on Doppler, but still suspecting a torsion.
patient is normal, he's saying.
Patient has pain, maybe. Yeah, the question.
Patient maybe has pain.
But
Just see, you
Doppler,
have to see again the tender ovary sign, look for uh, associated signs like fluid, look for the deviated ovary, the deviated uterus towards the ovary, peripherally arranged follicles, ovarian edema. All these things have to be looked for. And then eventually, of course, they will lead you to the diagnosis. There are some gray cases, yes, I agree too, but most of the cases you're able to solve following these pointers that I've told you. Okay, I've told you a couple of pointers for, I'll just repeat those pointers for the residents. All these, in addition to enlarged ovary and edema, you can see peripherally placed follicles, a displaced ovary towards the midline. Look for the pedicle. Look for the lead points. You see these lead points, and the ovaries transducer tender,
if
free
MR is
fluid
not
again.
there, how can we answer the, if MR is not there, is the question.
You can answer on ultrasound. MR is not rather the modality in torsion. It
Hmm.
can be done in problem solving cases. It should not be done as a routine in cases of torsion. They should be diagnosed only and only on ultrasound with these points.
Yes.
Because it is an emergency. MR is going to take its own time
Yeah.
and is going to waste the salvaging of the ovary.
Hmm.
That precious time for salvaging would be lost.
Yes. So last question, how common is ACOM?
ACOM is very, very rare. It has less than 50 case reports in literature. ACOM is a rare anomaly that has been recently described and has been and is considered a type of Mullerian anomaly by some, and has been described as that of a metaplastic or heterotropic origin only. Something within the uterine myometrium that could not develop a communication with the cavity, like a horn. Okay, lined
Yes,
by
ma'am.
the endometrial layers. So
Yes.
it is very rare,
Yes.
but
Yes.
needs to be diagnosed, needs to be kept in mind. Now that
Mhm.
people have described it, maybe we people pick it more.
Yes. Yes. Thank you so much, ma'am. It was very wonderful. I would like to thank the Viracto team for helping me to conduct this session smoothly. Over to you, Shweta.
Yeah, sure, ma'am. I can share tomorrow's flyer. Just a second, ma'am. The responses and requests are selected for both verified API and the connect and the generate again. So for the generate again, the transaction ID which we pass now, so we have a same name, but in the verification response, we see different transaction ID. So that's what we are going to put in the this is the flyer for tomorrow's session, ma'am. Yeah. That's all, ma'am. Shall I conclude the session, ma'am?
Yes.
On behalf of ICRI, we thank everyone for being part of this webinar. As a part of webinar team, this is Shweta and Janhavi signing off. Wishing everyone a very good night. With your permission, may I end the session, ma'am?
Yes, Shweta. Thank you.
Thank you, ma'am. Thank you so much.